Hi viewers, welcome back. In today's video, we are going to discuss about the premature rupture of membranes. Okay, actually, when are these membranes supposed to rupture? So, once the labor begins, once the labor is proceeding on the way. So, when you want to fasten up the labor progress, at that time there may be, due to contraction, there may be an natural rupture of membrane. Sometimes like we do it for like fastening up the labor process. Okay. So, anyway it has to be done only after the initiation of labor process. In case if this rupturing of membrane is taking place before the onset of labor, then we term it as premature rupture of membranes. Okay. So, that is with the definition, and then incidence, it is around 81% of the deliveries there is premature rupture of membrane. That is like we do not say it is exactly premature rupture of membrane. There are like once the labor process begins, sometimes it happens, sometimes like first the symptom will be the rupturing of membrane and then the labor gets initiated. So, anyway it is normal. Okay. So, it like when it is taking place long time before, then you term it as premature rupturing of membranes. Okay, then when we come to the etiological factors, why does this happen? The cause for premature rupture of membrane is like most of the time when the membranes are not having adequate strength. Okay, when they do not possess the strength to withhold contractions, at that time they will go in for premature rupture of membrane. That is like when the contractions are getting initiated, at that time only the uterine walls are like too much weak, and because of that they rupture. Okay, so that is like one. And another time it is like the intrauterine pressure is so heavy, and because of that it is getting ruptured. And like other than this, we have some other causes also, like other than this uterine. Okay, sometimes it is because of too much stimulation, that is like too much stripping of the membrane. When you keep on stripping of the membrane without the progression of labor, at that time there may be a premature rupture of membrane. Sometimes it is because of when there is a physical contact. So, usually we do not encourage mothers to have physical contact in the first and the last trimester. It is like to safeguard. Okay. So, usually you do not encourage in the last week, because like sometimes like this times like stimulation happens and like uterine contractions get initiated. So, some like because of that. So, usually you contraindicate physical contact or coitus in the later weeks of pregnancies, that is around 30 weeks, like that you can stop physical contact. Okay. So, with this like you can conclude these are the etiological features for premature rupture of membrane. Then we have the diagnosis. So, how do you identify whether this is amniotic fluid, whether there is rupturing of membrane, and how do you identify this is the ruptured amniotic fluid? Okay, so you have lot of tests which is showing whether it is amniotic fluid or not. Okay, so the first is like your visualization. Okay, so when you just open up and when you see the vaginal layer of the women, you can see it is wet. Actually, it is not supposed to be. Okay, so usually it is a dry area. Okay, and like in case if the woman is proceeding for labor, you can see mucus discharge, the mucus plug may be present, maybe bits of blood particles will be present. So, maybe like that it can be present, but you can, if you see the area is very wet, either you have to suspect there is an incontinence of urine, sometimes that can also happen. So, you have to differentiate whether it is amniotic fluid or it is the urine that is present in the vaginal region. Okay. So, that is your visualization, and then comes the nitrazine test. So, what is nitrazine test? When you have a nitrazine paper that is kept in the vaginal area, if it is an amniotic fluid, that is rupturing of membrane has taken place, and the fluid which is present in the vaginal wall is the like your amniotic fluid. When you keep your nitrogen paper in that place, you can see it turns immediately to dark blue, which is indicating the alkaline pH of the amniotic fluid, and because of that it is turning into deep blue. That is your nitrogen test. The next test will be your Fern test. So what is Fern test? Okay, so you take the amniotic fluid in a slide and you may allow it for drying. When you see, like after drying, when you see, you can see fern like structures that is present over the slide, which is indicating there is an amniotic fluid rupture which is present. Okay, then coming to the evaporation test. Evaporation test is you take the fluid and you allow it for drying. Okay, so after drying it has to be white in color. So in case if the deposit is white in color, it is because of the salts that is present in the amniotic fluid which is giving you that white color deposit. Okay, so that is your amniotic fluid which is indicating the rupture of membrane. In case if it is brown color or some other color, okay, then it indicates the amniotic layer is intact. Okay, so you need not worry about the rupturing of membrane. Okay, so then comes the ultrasonography. So ultrasonography, actually ultrasonography, when you do, it is not a major indicator, but once you do an ultrasonography, it can tell you how much amount of amniotic fluid is present. When you measure the sacs, you will be able to identify whether adequate amount of amniotic fluid is present or not, which is indicating the rupture. If there is a rupture of membrane, what will happen? There will not be adequate fluids presenting inside the uterus. So which is indicating the rupturing of membrane. So that is with your ultrasonography. And then we have intra-amniotic fluorescence. So you are going to administer 1 ml of sodium fluorescence in the amniotic cavity of the mother, and like after few minutes you are going to visualize that area whether whether this fluorescent is present or not. Usually you will be using a tampon, so you can you can push a tampon inside the vagina of the mother and you can wait for 2 to 3 hours. Like after 2 to 3 hours, what you are going to do is you take the tampon and you will visualize under the ultraviolet rays where you will be able to see the fluorescent material. So in case this fluorescence is coming out in the tampon, it indicates it is an amniotic fluid. Okay, so you are able to clearly understand this intra-amniotic fluorescence. And then coming to amnioscopy, where you don't go in for amnioscopy because it is an invasive procedure. Okay, so you have to put a scopy and you have to see how much amount of amniotic fluid is present or not, and whether there is any break in the amniotic cavity which is causing the rupture of membrane. Okay, so you have to analyze through an invasive procedure. So most of the time it is not recommended. In case if it is not rupturing of membrane, we are only artificially creating an premature rupture. So okay, so in case if it is needed, you go an amnioscopy, or otherwise you need not go in for amnioscopies. And then comes diamino oxidase test. This diamino oxidase test, it is an hormone which is present inside the decidua. And once this hormone, when you are going to test this diamino oxidase in the vaginal layer, it indicates how come it will come outside. It is from the amniotic fluid. So in case if you are able to detect this diamino oxidase, then it is an indicator that it is an premature rupture of membrane. And then coming to the fetal fibronectin. Fetal fibronectin is the enzyme which is present in the fetus. How come it will come into the vaginal layer? Unless there is a rupture. So when there is a rupture, you will be able to identify this fetal fibronectin. And the other test is also alpha fetoprotein test. So alpha fetoprotein is also present only in the fetus. So when you are able to identify this alpha fetoprotein in the vagina of the mother, it indicates that there is a rupture. And because of that, through the amniotic fluid, it is coming outside. Okay, so these are all the indicators like whether it is amniotic fluid or not. Okay, so whether the rupturing of membrane has taken place or not. So your visualization of amniotic fluid in the vulval region, and then nitrazine test, Fern test, evaporation test, ultrasonography, intra-abdominal fluorescence, amnioscopy, diamino oxidase test, fetal fibronectin, alpha fetoprotein test. All these presence indicate the premature rupture of membranes. Okay. Then we have the maternal and fetal complications. Okay, so you have complications from both the sides. Okay, so maternal complication, what is the problem with the mother when there is a premature rupture of membrane? Okay, so everything is complicated now. So now the woman goes in for labor before in hand. Okay, maybe it is by 30 weeks, it is by 32 weeks, 28 weeks, anytime this premature rupture can happen. So the mother will go in for complication. Okay, as well as the fetal complications. Fetal complication, so everything is complicated. So now when there is premature rupture of membrane, what will happen? There may be inadequate circulation, so contractions begin, there may be preterm labor, there may be fetal death, then fetal asphyxia, anything can happen when there is a PROM. Okay, so that is with your maternal and fetal complications. So management part, we can divide this management part into 3-4 areas. Okay, when the mother is in labor pain, so there is a premature rupture of membrane and the mother is having uterine contraction. So what we are supposed to do? So what? Never try to stop the contractions, because you can't. Okay, never stop the labor process, because like already the labor has initiated, there is no amniotic fluid, the contractions have begun and it is like proceeding. Now if you try to stop also, it is of no use, and no use of giving any tocolytics. Okay, if you give tocolytics also, the contractions are not going to stop, instead the baby is going to proceed, the labor is going to continue. Okay, so otherwise what you can do if you want to help the mother and the baby, you can start with the labor process. So you can start induction. Okay, so induction in the other methods, like we have already seen, like you can go in for prostaglandin administration, oxytocin administration, then stripping of membranes, all these things, like in case if the fetus is little mature and like if it is around 36 weeks and all, like you can conduct normal delivery. Okay, in case if the fetus is having an abnormal presentation, transverse presentation, breech presentation, in all these conditions, so what you have to do? You have to take the mother for an LSES session. Okay, so that is with your when the mother is having labor pain. See, another thing also we can do, what we do is like amnio infusion. So what is this amnio infusion? Okay, so now amniotic fluid is leaking and it is coming down. Now we have to help the mother. So what we are going to do? We are going to artificially provide fluid to the like sac, amniotic sac. So now we are supposed to, you take saline and you will warm up the saline. Okay, so once you warm the saline and you can administer, like using a 3-way adapter, you can connect it into the amniotic cavity. Okay, so you can go and reach the posterior area of the cervix and you can start like infusing. So once this fluid is getting infused, you can to the maximum of 250 ml you can administer within half an hour, and like maybe with a half an hour break again you can administer another 250 ml. Like, so in case if the woman is proceeding, she will proceed and she will deliver, till that time you can help in. That is one amniotic infusion procedure what can be done to help the mother and the fetus, like in case until they are getting delivered, the fetus is on the safer side. Okay, then coming to the area where the mother is having infection. Okay, so now there is a premature rupture of membrane. You know, actually this bag, your amniotic fluid, what it is, a protective bag. They are protecting the fetus. They totally, completely take care of the fetus. Now the rupturing has taken place, and what is happening? You are giving a way for the infection to take place. So sometimes what happens, like as soon as the rupture starts, maybe there is a mild infection entering and it will proceed. So once the infection process has started, you have to start with antibiotic. So now in case if the baby is not delivered and the infection has already started, you have to start with antibiotic, and whatever antibiotic you are continuing now, that you have to give it for 7 days for the fetus after the birth. So now in case if you have not started with any antibiotic now, then what you have to do? Once the labor is over, you have to do an culture and you have to start antibiotic for the baby after the delivery. Okay, so that is with the infected PROM cases. Okay, and then the mechanism of delivery in 3 areas. Okay, so one is like premature rupture of membrane between 32 to 36 weeks. Okay, so now 32 to 36 weeks you can consider, because the baby is grown up, the structural development has taken place, the baby will be little more mature. Now we are worried about the lung maturity. So now you have to assess how is the lung maturity. Okay, with that, in case if the baby is okay, then what you can do? Then you can conduct normal delivery. Okay, so how you will do this? So now if the baby is around 32 weeks to 36 weeks, you are going to see the lung maturity. So you will assess if the baby is able to survive in the external environment. So if it is so, you can help with amnio infusions. And the next complication is the infection. Amniochorionitis can happen. So you have to be cautious from that part, and like you can use the other methods, like you can fasten up. So in case the labor is getting initiated and you want to conduct a delivery, you can use the other methods of induction of labor, you can proceed and you can deliver. In case if the baby is from 32 to 36 weeks, according to the maturity of the lung, you can proceed. In case if the baby is between 26 to 32 weeks, what you have to do? You have to take the women in for a admission. Okay, so what you have to do is take the women in an area, in a room, or in a hospital where there is an adequate bathroom facilities, where the mother need not walk too much. See, now when there is already a leak and if the mother is walking, what will happen? Again the fluid will drain because of gravity. So now she is not supposed to walk. Provide complete bed rest, and now your amnio infusion is going to play a major task. How long it is possible for you? Until the maturity of the lungs takes place, until the baby is capable of surviving the extrauterine environment. So till that time you can proceed with your amnio infusion. And in case if you suspect infection, you have to start with antibiotics, that is with your rupturing of membranes between 26 to 32 weeks. And one more point you have to remember when you are taking care of babies from 26 to 32 weeks. So now I said, like, if the lung maturity is not adequate, you have to administer betamethasone. Okay, so you can administer betamethasone in 2 doses, like 24 hours apart. You have to administer 2 doses of betamethasone, that will increase the lung maturity of the baby. Okay, and you have to continuously monitor for the fetal well-being. You have to do a CTG, and you have to assess whether the baby is having infection, whether the mother is presenting with any signs and symptoms of infection. All these things have to be ruled out. In case if you are ruling out, you have to start with the antibiotic. Maybe your ampicillin will be the drug of choice. Okay, so you can do that with your mothers presenting from 26 to 32 weeks. Okay, so next, coming to the rupturing of membranes before 26 weeks. Now if the rupture has taken place before 26 weeks, you must prepare the mother that the prognosis will be very poor. There will be perinatal losses. Okay, you have to prepare the mother, no other way. Okay, so but you can try with the other modules. You can start with drugs. Okay, so you can start with tocolytics. Sometimes they may stop contraction, very rare conditions it may stop, and you have to start with the glucocorticoids, phenobarbital, and like all these are like preventive measures to stop contractions. You can give antibiotics, and vitamin K administration can be done. All these are methods, like in case if the baby is getting delivered, like you can protect. If not possible, then we are helpless. Okay, so this is with your premature rupture of membrane, where we have discussed about the definition, incidence, etiology, diagnosis, where we have seen all these areas of assessment, including visualization, nitrogen test, Fern test, evaporation test, USG, intra-amniotic fluorescence assessment, amnioscope, P-dye, amino oxidase test, fetal fibronectin, fetal alpha fetoprotein, these things assessment, and the complications of premature rupture of membrane from the maternal and the fetal side. As well as we have seen the management in 4 different areas, like where we have seen as the mother has proceeded into the labor, where the contraction has already started and she is proceeding into labor, what is our role. We have seen the management when the mother is infected. We have seen the management from 32 to 36 weeks, management of mother from 26 to 32 weeks, management of mother before 26 week. Okay, so all these areas, when you get a question regarding premature rupture of membrane, once you write all these topics, this will be sufficient. Definitely you will get full marks. Okay, and you have to read all these areas. Okay, so this will be like your small answers, and like where you will get these type of questions in your viva. Okay, so viva question, these are all your viva questions. Definitely you will get anything they will ask you. Okay, sure, important questions from this area. Okay, so with this we complete the premature rupture of membrane. In case if you have any doubt, kindly go and ask your doubts in the comment box. Okay, and if you want any other further topics also, you can give it in the comment box. So let us see in the next video. Until then, goodbye, take care.